If you have a question, please wait for the microphone, or you can go to the microphone stand and ask your question so everybody can hear the question that you're asking. Thank you. Our next speaker is, once again, Dr. Irigoyen, who presented earlier this morning, and he's going to talk this time about behavioral disturbances in Alzheimer's. We sincerely thank him for his time and for spending his entire day with us. Thank you very much, Doctor.
Well, good afternoon. Hello again. You wonder, Dr. Irigoyen to present twice today. This talk was originally going to be given by Dr. Irigoyen. He had an important compromise at the other side of the sea. Imagine, he's having a great time. Okay, and actually, I made a couple of jokes about my name when I came for the first time. Now it's Dr. Irigoyen's turn. Irigoyen means in Basque the hill, and my name Irigoyen means to be on top of the hill. So I say, oh, but you know, I've been in McAllen for 20-some years, and there's still some people that call me Dr. Irigoyen. He said, no, Irigoyen is a short name. Irigoyen is a long name. Oh, yeah, I see. Then how is my name? Oh, Dr. Irigoyen. Oh my God. I found finally a formula to deal with this, and I tell people my name is easygoing with an R. Let's try easygoing. Easygoing. Irigoyen. Oh, you got it. Okay. So, Doctor Easygoing with an R? Oh, okay. This topic actually is a little bit more in tune with what we do on a daily basis in places like the Geriatric Unit in Renaissance, or the other hospital. The other hospital, we won't talk about them because we're with Renaissance. And basically, you know that in this time that people have to have indications for everything, or appropriateness, and treatment, medical necessity, all those kinds of things. If you had what is called senile dementia of the Alzheimer's type, that's not good enough to go to the hospital. There are tons of people that have that. There's tons of people that have Alzheimer's disease, or the so-called AD. Now it's called AD2. And it's going to be called neurocognitive disorder, right? The thing is, that's not enough to justify being hospitalized. You have to have something else. What is this something else? Well, many times it's aggression. Many times is depression. So there's a condition called dementia with depression. There's another called dementia with behavioral disturbances. And possibly the most important one in this name is dementia with delusions. That should be called dementia with psychosis, or psychosis in the context of dementia. The message that I would like to give you before we go over all those things here in the way Dr. Irigoyen put them in his slides is that it's very important for clinicians to actually pinpoint these conditions, separate them from the basic Alzheimer's. Why? For one basic reason. Depression does have treatment, and people respond to treatment. Delusions or psychosis has treatment, and people respond to that. So, if we think in this as a separate condition, we are most likely going to find something to treat, and many times in cure that particular problem. We are still left with the Alzheimer's part, okay? But actually we can do a lot to help people that have these so-called behavioral disturbances. Dr. Irigoyen makes here a point that this is not an issue just of medication. There's a long section, and we'll go very fast over it, that has to do with using medication and has to do with her question is why to use antipsychotics in people with this type of problems. See, what I was saying. Also, not only geriatric units in psychiatric hospital, but also nursing homes. Of course, I don't recall that caregivers have told me that they're very stressed because the person forgets things. But many times you hear the caregivers complain about things that the patients do. Sometimes there are things that perhaps are not that bad in a way, but they have consequences. Perhaps the worst example, just abounding in the examples that we were hearing from the Alzheimer's Association people. I had this patient in a nursing home that managed to escape a lot from the nursing home. She was found sitting on the top of an anthill. She had to spend, I think, 2 or 3 weeks in intensive care unit with more than 200 or so ant bites, almost died. And you say, well, my goodness, is that a product of the Alzheimer condition? Yes, it is. Things happen. We have to be very careful with our loved ones that have these conditions. And this is very, very essential. If we have somebody in the house that they are safe, and any type of measure is justified to prevent them just to wander off. That is one of these behavioral disturbances that perhaps is poorly understood. This is an issue for everything right now. Of course, behavioral disturbances are going to increase not only accidents like the one I was mentioning, but in general, mortality and morbidity. I mentioned this in passing in my prior talk, is that a person with Alzheimer's doesn't have the ability, the capacity to tell us what is happening to them. So many times we take the person to the doctor for a medical problem, and it is too late, or the problem is too advanced, because these people did not, or were not able to communicate that. The last point is actually FDA seems to have a campaign against using these medications in the elderly, and they have put this thing that they call a black box in each one of the antipsychotics particularly. This is, if you use this in a person with Alzheimer's, you have to be aware that that increases the risk of mortality. I question if this is a good thing to do, because actually the people that need more medication are the ones that are sicker, and the ones that are sicker are the ones that tend to die. Perhaps it's not the medication, perhaps it's that just we're looking at 2 different groups of people. But difficult to tell the government, hey, look back at that. That any antipsychotic, even the new ones that have not been tried even with the standard things, has that particular black box. What we have here, what is called the comprehensive assessment. Important to see what is really going on around. When you ask a person that lives in a nursing home, why did you do that? Usually they tell you, it's because him, the guy in the next bed, making too much noise, snoring, spitting on the floor, he wants to speak with me when I want to sleep, etc. I say, well, they blame the others. And many times, we are lazy in responding to these type of things because it's easy. Well, let's see if that's true. Let's move this person to another room. So difficult in a nursing home to move a person to another room. I think it's easier to get 200 illegal aliens to the river than actually move a person from one room to the other in a nursing home. But that's my opinion on it. Dementia itself. Of course, well, dementia may lead people to wander, to be inappropriate, to be aggressive, to be loud. This one, delirium, I think anything that we emphasize about that is very little. People with Alzheimer's disease also have other problems. You know, when your brain has come of age, your prostate also has come of age. So many people have, you know, urinary retention, urinary tract infections. The basis of the lungs are, you know, a good site to develop infections of many kinds, bronchitis, whatever. And all of those things are manifested by behavioral disturbances in a person with Alzheimer's disease. The next one is basically the same. Medical problems, should be. Do you know how many medicines, how many drugs, in average, a person in a nursing home takes, no matter what they are in the nursing home? You take all of them and take how many medicines they take and say, how many per person? About 15, yes. You know what 15 meds do to a person? You know, you can try. You know, when I lost my leg, oh, my poor leg, okay, you know, they gave me something called morphine, something called hydrocodone, and something called fentanyl. You know what happened to me? I started seeing spiders, worms. Then I thought that I had died. And I thought that they had removed the... I don't have Alzheimer's dementia, but just putting drugs. And these people are taking sometimes 15 drugs. Okay, wow. Of course, this one is a very important thing. There are many reasons for a person with Alzheimer's dementia to become also depressed. It can be a reactive depression. I notice that I'm losing faculties, okay, or people put me in this damn nursing home and they don't come and visit. Okay, you know, in any nursing home that you go, you're going to find Johnny that is looking for his brother or somebody, because the brother said that he was going to come pick him up and take him to have some pizza. 2 years ago, 3 years ago, and this, it wasn't the problem in Alzheimer's that people lose memory. There are certain things that become recorded. I think it's very important that when we are caretakers, never do promises that we are not sure that we're going to be able to fulfill. Particularly that kind, something that is very exciting. I want to take you bowling, we want to go to the movies and have some pizza. The poor guy is so exhilarated, is the word. So, and that never happens. The person is going to get very disappointed, close to depression. Now, depression is a common condition, but imagine have Alzheimer's and in addition have major depression. Well, that's kind of raining on the sea, right? What you have next? Anxiety disorders, the same stuff. And personality disorders, I mentioned this briefly in my other talks. I was, if somebody was an SOB 25 years ago, now has Alzheimer's dementia, unfortunately that SOB part doesn't get better. It tends to get worse. This is the This is a good definition because it's a basket that gets anything that puts a person in risk is a behavioral disturbance or a behavior that makes keeping the patient in the milieu difficult for either staff or other patients. Remember that this talk was designed to kind of figure out indications to place a person in a nursing home or in a psychiatric unit. And yes, when behaviors get on the way for that person to remain in his own house or the like, so whatever that is, it's time to think in moving to another level. Because actually, as good clinicians that we are, we try to help the circumstances or whatever is happening with that person, or, and basically help the person to stay in the lower level of care. Why? Well, because simply we believe that the best placement for a person is his own home, with his own family, in a familiar environment, and other placements are just alternatives when they are necessary, right? Here there's a number of examples about behaviors that are commonly brought to the attention of particularly psychiatrists, but also general doctors, and or even the counselors that work in a nursing home, for example. Hitting, kicking, well, screaming, constant calling out. You know, this person that is in a nursing home with, you know, shouting, "Help! Somebody help me! Help!" You know, nursing home sometimes transfers that patient to a psychiatric hospital, so the help me, somebody help me, goes to another place and they can rest from it. When the person goes back to the nursing home, the person is going to continue saying, help me. It's one of the most difficult type of behaviors to correct. And it takes what? It takes patience, takes consistency. One of the problems that we see in our local nursing homes is that there's a day staff that has one philosophy and a night staff that has another philosophy. Night staff usually wants just to be in the nurse's station and not go into the patient's area, and that doesn't work. Simply, all the staff has to work with the same. Possibly it would be better if all the staff ignores this help, or if all the staff goes and attends that. When it is inconsistent, the behavior tends to stay there. Sexual disinhibition, verbal, physical. I used to say a bad joke about myself. I said that when I'm called to nursing homes, I'm called because the patient is either hitting the nurses or pinching them. I say, when I get old, I'm going to be the second kind. However, this is a big problem because, you know, these behaviors can be directed to the staff needs to know how to deal with them, but it can be directed to other patients. And something that is, let's say, something like flirting that is a little bit out of control may become in a physical fight. And problems for the patient, problems for the other, or problems in the, let's say, the legal sphere. I had my mom in a nursing home, and this bastard came and told her some things. You know that's good for a lawsuit? Yes, it is. And there are lawsuits in that thing. You know, that place is not taking care of my mom because they are allowing this, you know. Yeah. And of course, aggression, this is during daily care. It's one of the most common problems that we see in nursing homes and also in the hospital, is that people that are perfectly peaceful, when they are pushed or pulled into taking a bath, changing clothes, being calmed, they start, they simply feel they are Pacquiao or Cassius Clay or something like that, and start hitting people. It was fine. Yes, I think what we need to have here present is that can happen to many of our patients with dementia of any kind. And we have to be careful because, you know, our noses are a risk. This little old lady that looks like, you know, throws candy, whatever, says, "How are you, mommy?" Fine, okay. I got a scratch on the face one time. I've been very careful since then. And finally, what I call attention-seeking behaviors. We have to be careful in labeling some things, you know, attention-seeking. Attention-seeking can be our perception of something that person. Remember that these people cannot communicate well. So why do we think that they just are looking for attention? It's something that we bring from our homes. Is nah, there's nothing wrong about my grandmother does the same thing, you know. She always says, it's hurting. Okay, no, we better take seriously those things. Objectives make the behavior wait, prevent the underlying cause, not always easy. Improve patient outcomes. Well, of course, if the patient is calmer, is more at ease, you're going to have a better. I don't know what this means. Yeah, well, everything you know has to do now with HIPAA, with OBRA. There's a big brother, you know, watching us. But you know, we better get familiar with these requirements because actually being compliant with OBRA guidelines, for example, this type of problems, makes us more effective in this environment. Restore calm and safety to the situation and the unit. Remember again that this talk was designed for psychiatric units. This is a classic way to examine behaviors. What was happening right before the behavior? Oh, there was a fire alarm. Oh, fire alarms, you know, and most of them are just drills. They drive people, excuse my language, they drive people crazy. You hear a little dementia, you know, you come and going, and then you hear basically that leave the unit to the marked exit, and you see all these flashes. Who designed that? I don't know, but I suppose it was an intelligent person, and I suppose it's for a good reason, right? Are we thinking in our Alzheimer's patients when we set up that type of thing? Okay, behavior. What is really this person doing? Johnny wakes up 3 o'clock in the morning, goes to the restroom, and gives a kick to the commode, and then goes back to his bed. Ay, ay, ay. What does that mean? I leave it for you to decide. Consequences. Well, perhaps after doing this for 7 or 8 years, the commode is going to break. What do you mean? Things like those are not a big deal. Don't fix what is not broken, okay? Dr. Igor puts here detective work like that. Identifying environmental stressors, okay? That's not very easy sometimes. Speaking about staff, what happens when you have the nicest nurse during the day shift, but at night there's one that comes and says, "Hey, mami, no estés chillando. Shut up." That actually gets people very confused. Actually, you know, in my experience that I have with nursing, especially having been a couple of months in the hospital, I find that nurses are 99% of the time very nice. What happens when you find one that is not nice? I don't want to have that experience. Any trends? Many times the call for, hey, we need to put this guy in behavioral is for one behavior in months. Never happened before. I would say, not a big deal. Let's wait a little bit and see if it happens again, right? Working on a crisis plan per patient. Well, it's when you have discovered a trend, it's important to kind of to have certain consistency. What we're going to do next time it happens. This is a good one. I don't know how to do it, but you know, I know people that know how. You know, I had a patient in certain nursing home here in town, and I noticed that the patient had a kind of a special preference. Why? I want my patients. I'm glad that my patient is getting this royal treatment here. When I figured it out what it was, I said, oh my goodness, we're human after all. You know, the son of my patient, a multimillionaire, would get to the nursing home and distribute little, you know, this, how they call them, ID things with portrait ID with, you know, Franklin and Washington Post. All the staff will get tips. If it works, why not? If it's just mom. You can buy some donuts on the way to the nursing home for the staff. Why not? Staff needs calories. Then Dr. Igor put this. I'm not going to go over this because this is identical to my slide, and also I think we all have presentations there. Again, look at this. Now it's behavioral. What is it? What is the title of this? Okay. Problem. Why is it a problem now? This is a good question in general, and it's something that we deal in a weekly basis. And I use the expression weekly because it's weekly. Every Friday, a behavior that has been tolerated at the nursing home through the week becomes intolerable. And this patient needs to go to the hospital. Why? Oh, weekends are staff problems and stuff. Whose problem is it? This is an easy question or difficult question depending upon how you see it. The way I see it is somebody wants his problem to become my problem. But sometimes, I'm in this business because I like to deal with problems. Sometimes, is there a safety risk? Prevention? Okay, of course, understanding is important. This is very, very essential. Remember in the other talk I was saying about looking even in all records. I think it's very important to have as much information as you can, and from several different sources. Family is going to tell you one thing, the provider is going to tell you another thing, the nursing home is going to tell you another thing, a daycare is going to say another thing, and the van driver, those are very important. Whose problem is it? Is the behavior problematic for the patient? One of the things that dealing with people with Alzheimer's disease, teaches you is that many times the person with Alzheimer's disease is actually this is right. The caretakers are the ones that are taking the load. But this guy that just wants to wander off, etc., he's not conscious that he's going to suffer because of that. And we better realize that that's when we're trying to change that behavior, possibly we're trying to change a behavior that the person likes. It's not like something, we are the ones that don't like the person wandering off. But the patient may have made a goal of his life to be able to escape from that place, right? It's endangering. This seems to be the most important factor in dealing with behavioral disturbances nowadays. Is how dangerous is this for the patient or for other people. Irritating, upsetting. I heard a couple of months ago a very interesting statement in part of the people actually funding a nursing home here in town. They were trying to place the patient in the hospital because the patient was not sleeping and was wandering in the night in the nursing home. And the agency told the nursing home, we pay you to work nights. So if the person is, pacing the night, you have to have people go pace with them and see what's wrong with them, regardless the time of the hour. So, hey, that's interesting. They say these things to prevent themselves from paying for a sleeping pill. But be ready for more of that. It's going to come. Staff interfere with care. This I have mentioned already. With all staff, just one staff. Well, that is as the doctor before me was saying, is that's human nature. Some people like some people and dislike others, and unfortunately, that's the way. The good ideas by Dr. Irigoyen. If our place has places to wander, to pace, to walk, digital hidden locks. Okay, well that's pretty sophisticated. You go here to our hospital system, and wherever you go, you need one of these to go to certain doors. And I think this is becoming a universal feature in all hospitals, etc. That you need a magnetic thing to get in and out. And of course, well, this is thought in function of protecting the patient. Electronic bracelets and wonder guards, well, double bolts. Double bolts on doors. This one, we recommend highly to families to use these double bolts. That means only to put, well, you have to open this and this at the same time in order to be able to go to the other side. You know, many people with dementia figured it out. It's like these little flasks that they sell that children proof. Oh, children are very good to open them. Puzzle, shows, whatever, half doors, all half doors. How is a half door going to work? Yeah, actually, they're among persons with AD, they're climbers. And the half door is going to help them to fall from a taller place. So, watch that. Flexible team, things to do. Oh, this one. I think this is extremely important. You have something that is called an Alzheimer's program, Alzheimer's unit. Be sure that you keep people busy. That will reduce behaviors tremendously. Of course, you know, activities such as you know, taekwondo, boxing, stuff like that are not very recommended, but you know, other kinds of things. This is not a good idea. Highly patterned wallpaper. I was called one time to Mission Hospital to examine a person that was seeing animals on the wall. And I got there, see, Magnus, has you seen animals? Yeah, she's seen animals. Well, show me the animals. Okay, here they are. Okay. Yeah, there was Mickey Mouse, Minnie Mouse, Goofy, Donald Duck. Is that in winter time, you know, there are many winter Texans, and they use the pediatric unit to house elderly people. Okay, well, yeah, not a good idea in a geriatric unit. Mirrors sometimes are confusing because the person thinks they are not themselves with somebody else that is kind of making faces to them. Oh, yes. Anita, state your location. Anita, state your location. Anita, state your location. Doctor, I'm hearing a voice that comes from the... Yeah, I'm hearing the same voice that you are. Dr. Irigoyen show good humor here. CNN and soap operas. You know, although I think sometimes a soap opera with good, you know, tragic scenes helps people to kind of paint some emotions. And sometimes these people in the tube are more effective than we are to bring up emotions in rigid routines. Okay, yeah, rigid routines are not well taken by people with Alzheimer's disease or with schizophrenia or with anything. Even normals have problems accepting rigid routines. You know, the only exception is military people. Medication is not that effective. And it's interesting because, you know, as a psychiatrist, the times that I feel like a hero is when they take me a patient and they prescribe something and that something makes a difference. But in these things, there's not a big difference. Sometimes you get more by reducing medication than by increasing medication. Why do you think is that? Yes, that people get halfway drunk with, you know, 200 milligrams of something that if they are just going to get 50 milligrams, they'll get the same effect and won't be groggy, whatever. I think you have a point, yes. Yes. Sometimes they don't. And sometimes it's very difficult to convince everybody else that they don't. You know, that's something to consider, you know, when you pass judgment about Dr. So-and-so and Dr. So-and-so that uses a lot of medication, etc. Many times doctors, you know, just respond to the call, somebody, they call you in the evening, this guy is doing this and this and that. What do we give? They don't expect that you check all the medicines and say, well, let's see what we take away. Oh, well, let's give this and that. Even, we have worked hard here to create protocols that are given automatically to people that are disturbed in the middle of the night. That means more medication, nevertheless. Let's see what we have in the next one. We go back to the double locks and stuff like that. And okay, challenges, repetitive questions. Where's my wife? What do you answer for? You get a question like this. When am I going home? You're home, Daddy. This is your home. When I'm home, you're home. Where's my wife? Over there. My answer for this is a little heterodox to say, what do I answer, doctor, for questions like this? And I say, well, it depends on how much time you have in your hands. If you have the whole afternoon there, to be there with your dad, you can sit down with your dad, calm down, let's talk about this. Mom died several years ago, we have been to the cemetery several times. If you want, we can go and visit her, well, you can go with the truth and nothing but the truth. But if you're in a hurry, and you have to explain, where's my wife, when the wife has been dead for several years, it is okay sometimes to say, I am going to HEB, when I'm back, we'll talk about it. When am I supposed to go home? Al ratito. Wait a little. We'll get there. One of these days. So the answer depends more on you than the question. Anyway, it's not going to work. You'll have a chance tomorrow to try a different answer, because they're going to ask the same question. See, screaming, later stages of dementia, the broken brain, And again, I think the big point is medication has little efficacy when the problem is basically screaming. What is this one? Screaming. Non-pharmacological, increased socialization, increased auditory stimulation. Have you heard about this one? Simulated presence therapy? Who can tell me what it is? Simulated presence therapy. Dr. Gua put all these question marks there because there's a debate if it's a good or not thing to do. But what is it? What is it?
I know, but what you mean is that you present the patient with white light.
Okay, well, in a way, yes. Well, this is a technique that involves recording familiar voices. You record the voice of the wife, record the voice of the sister, or whatever, the person that is important for the person that he's acting for. And when they start, you turn it on. Do you think that would help a person with Alzheimer's? No. That's one point. Researchers that propose this technique are very, very, I would say, fanatic that this thing works and people get appeals and they have had good results. I think it may be worthwhile to try it in an individual basis and see if my relative responds well to that. But please.
Similar to music therapy? Music therapy?
Yeah.
Similar to it, except that it's not the voice. But you transfer the patient to wherever the music is.
Sure. But I think, I would tend to endorse more music therapy than recording, because there's another factor that we never know if this person actually does have a positive affection for that voice.
Presents peace or presents time.
Mhm.
I could see how it could be a benefit, like, in saying when I was a child, my dad was overseas a lot. He would record messages and send it to us in a tape.
Mhm.
And it was something nice that we received. So it could help in that instance, maybe a message from a loved one to help calm the patient. In instance, I'm a geriatric nurse at behavioral, so it could be like a message from a family member saying, this is so-and-so, I can't be with you today, but I just want to let you know that I'm thinking about you and I love you, and it could help calm the patient in that instance.
What can I say? It makes sense to me. But you know what? One of the things that that perhaps you know, when I saw this entry there, I think I'm gonna stop there and reflect a little bit about this, because I think, you know, that even though it may work or not, you see that with very simple means like a tape recorder, you actually can have a form of experiment that you can do. This is very. I think it would be very benign. If it doesn't work, it doesn't work. But you know, but see how there are people looking for answers that are not expensive, that you can do wherever you're at, and your creativity still allows you know, to come and create something for something for people with very little investment.
Cuando escucho hablar de esto, doctor, una de las cosas que viene a mi mente es el beneficio que puede traer para el que da el cuidado. Y a la vez entonces es un beneficio secundario para el paciente, porque al disminuir el nivel de ansiedad, porque estoy haciendo algo por ti y nada parece funcionar, porque no funciona el simple hecho de tener el beneficio de creer que estoy haciendo algo, pudiera tener algún beneficio en mi atención hacia el paciente posteriormente. Pero sería una ganancia secundaria, no sería directamente.
You know, I think you have a great point too, and this is, you know, I think we see that all what we're trying to work, helping other people, we know that if we're happy doing that, we're going to be able to help these people more, because we're going to give them our own joy. If we are a bunch of sad caretakers, all of our, you know, loved ones, or so. What do we have here? Verbal and physical aggression. Okay, yes, as always, the sooner you get in the, I think the better results you're going to have, like avoid situations that are known to be provoking for the individual. This has a practical thing. You know, I get to see a patient for an evaluation for Alzheimer's disease. Sir, can you tell me what day is today? Okay. No. Okay. Can you tell me where are we at right now? What's the name of this place, madam? Do you know we are in the building? You know, you see family members learning the questions that you're asking. A year later, you see the same people and say, let's say, Papá, ¿sabes dónde estamos? ¿Sabes qué día es hoy? They're repeating the same questions I ask. Hey, that's not the role of the caretaker. This is the role of the doctor to figure out what's wrong with this guy. You know, the carer, the caregiver, you know, has to tell this, hey, Dad, today is Monday, and it's the 13th day of the month. And you know, we are Dr. Irigoyen service. Just give the information, not continue challenging the person. And of course, the poor guy is going to get all wired out, because he's asked the same questions. Not only they ask the same question, the relatives ask the same question because they think that's the thing to do. When we're examining a patient, we have to be careful in that people really realize that we are examining the patient and not that we are teaching them how to deal with them. But they learn that pretty well. Even after years, they are still, ¿sabes qué día es hoy? Yes.
Most of the time, we lack in educating the family in the process of the illness, the discourse of the illness, the effects it's going to have to them as well as to the patient. So you bring up a very good point. And sometimes as professionals, we lack that.
This is a good one. avoid arguing or confrontation with, especially with a patient that is already fighting. You know, a person that is already fighting is a person that is already out of control. Okay? Your hospital, your nursing home, your residency, your attended, your assisted living facility doesn't need two people that are doing the same thing. The people that advocate for these kind of things. What do you mean you don't want to be here? Don't you understand? I want you to be here. That used to be called direct analysis, that type of thing. It never worked, but it still has some advocates. Beware. When a person is shouting, yelling, etc., try to control that with whatever means you have, being as calm as possible. The unit doesn't need two people. In this case, with one is enough. This is just a approach slowly from the front. I've seen this type of advice. You have to be careful in giving it. Okay, when you have a patient with Parkinson's disease, and you pull this person, or you pull the person from the wheelchair, what's going to happen? Well, the patient does, it goes over you and boom, falls on top of you. So, important to approach from the front so they see you, but then don't pull them from the front because they're going to fall exactly on top of you. In all the books of gerontology, it says that all people respond well to be touched. You should never touch to young people because young people actually take this in the wrong manner. They may fall in love with you or whatever. You know. The thing is that all people respond well to touch. Careful. Careful. There are still people that are looking for a good reason to sue you, and that can be as good as many others. So this word is very important. Judiciously. Touch judiciously. How's that? Oh, sorry. Absolutely true. Many times we try to focus on the behavior to correct it. And it may be okay. When I went for the first time in a psychiatric unit, I noticed that they did two things there. One was to put all the people in a room like this, and all of them would talk about their problems. Yeah, no, my problem is worse than yours, you know. Well, not only my wife, they hate me, my mother hates me too. Okay. Oh my God, people are wrong. They had another type of therapy that was called volleyball. And you know, I had difficulties to figure out which one is more effective. You can get people to do something, hey, stop the fight, let's go play basketball, let's shoot some basketballs, or let's do this or that. That's going to work as good as trying to resolve problems, and more in this age group. Unfortunately, many times we're short of staff, or we don't have the facilities, or it's difficult even for purposes of safety, to take one old person out from the unit and have them walk around the hospital, stuff like that. To start with, it's very hard around here. Avoid the use of physical restraints. Well, everybody's committed about that. I'm not that sure that that's the thing. JCHO wants restraints to disappear from our facilities. But you know, this thing comes in waves. There's going to be a wave that says, no, okay, you know, chemical restraints are worse than physical restraints. You cause more damage by injecting tranquilizers than by putting restraints, if you put the restraints appropriately. There's going to be another kind of coming and going. I don't want to be cynical, but I don't think, I think that what they don't get is that, there's not a one answer written on stone for all types of these problems. I think we have to be creative, and sometimes even we have to try exactly the opposite that we tried last time to be effective with this type of things. This is an interesting slide, and will quote the author, Dr. Irigoyen, in this one, because I think he put together things that are very common in our units. Clothing, need to toilet. We're talking here about sexually inappropriate behavior, whatever that is, okay. Need toilet, UTI. Yeah, when a person has a urinary tract infection, they may be hyper aroused or so, or be soiled. And this is perhaps the main observation there is that it doesn't need to be sexually related. One time I was called to this nursing home and say, what's the reason you're calling me? We'll be calling you because Mr. Jones has offered $20 to the nurse to have sex with him. I say, hey, that man is totally crazy. You don't get that from less than 50, okay? Somebody placed a complaint about me saying that, but you know, the thing is that perhaps my message here is many times what a person expressing this type of thing, sexually inappropriate behaviors, they're actually expressing something else. They are expressing their need for companionship. They are expressing their need, perhaps like in this case that he wanted to buy sex, his need to stay in control, having power. You know, you have heard the expression among younger and non-Alzheimer people saying, oye, si mi dinero también vale, my money is as good as the money of everybody else, why they do treat me differently, right? So, well, it's because you're old and she happens to be a nurse and is married and has a life outside this place. No, this is the real reason why this person is not going to accept $20. Another reason is that she has different moral, ethical principles. But are we attending to what this guy is asking for? He's asking for companionship. He's asking for some tenderness. How to give it, well, it's difficult to figure out, but certainly, you know, I think accepting the $20 would be the worst type of thing. You know that happens once in a while. Pobrecito, estaba tan solo, that's why. No, see. I think if we have to help people, we have always to keep our role as helpers and not to get enmeshed with the things. We have pretty good cases here in McAllen, the people that did not distinguish the boundaries and that type of thing, say, how is it possible? It is. We have to be careful of our own response, especially with things like this sexually inappropriate behavior. Found undressed, calmly bring a robe or blanket. You know what happened with that robe or blanket? Marianne, what happens with that robe or blanket? Thrown back to you, right? Okay, use a matter-of-fact approach. Possibly this is the most important thing. Hey, not here. Go to your room. Okay. If found masturbating, is that common? Ooh, yes. Do not react with upset or ridicule. Gently lead to a private place. You may or may not wish to distract with a tactile object. Again, this is Dr. Irigoyen. I don't know what he meant by this. You would agree with me that this is an excellent summary of everything that you can think about these kind of things. He actually did a terrific job putting together these slides. I think we have about that. Here's a little summary about delirium, that is a common cause for so I think it's important to get to what is causing this problem. As I said, the common things are urinary tract infections, bronchitis, something that they call urosepsis, is that the germs go to the bloodstream from the urine. And but also things that we have to think about is old people have old bones. I've seen at least 3 times a person having bad behaviors, and actually, after trying to figure out what is happening to this person, we found he had a broken hip. Not enough to invalidate the person, but enough to cause pain, constant pain. As soon as the pain was controlled, the person was fine. Imagine that kind of thing. Possible causes. Oh, here, 92%. Ah, that sounds very expert, guys. A bunch of people. Oh, that sounds very unprofessional. A lot of people I see. That sounds a good thing, right? A lot of people that I see, I am doing the mental status examination. Say, Mom, could you tell me what day is today? Oh, what? What day is today? What? What day is today? Mom has a hearing aid, but she never uses it. Oh gosh. Sometimes to evaluate people, we have to realize that they don't only have mental problems or Alzheimer's or you name it. If they don't hear, it's going to be very difficult for them to get anything that you say or you want to know. And their answer is not reliable. Cataracts. One of the common things that I see in the office is they bring this person to me because he's seeing things when it's dark. Cataracts. They see things in front of their eyes, but they cannot figure out what they are. Got possibly to important thing. Do you know what the psychosis is? According to DSM-4, they changed the psychosis in the old days was to be disconnected from reality. But that's difficult to test. So DSM-4 decided that psychosis was an illness with psychotic symptoms. Oh my God, what a definition, right? Oh, but psychotic symptoms are hallucinations, delusions, bizarre behavior, catatonia. Those are psychotic things. When a person that has Alzheimer's disease starts saying that the Virgin is coming every night to give him a good message, or they hear the voice of somebody calling them, or they posture, or they get somebody, and then we can say that this person has dementia with delusions or dementia with psychosis. And then what it is important is to separate those two so we treat the psychosis as I was saying. Look at this that he wrote in the last line. The working diagnosis indicates duration of treatment. That's important because things are getting tough in this area, and it's important to say we're going to try Risperdal for 15 days and that's it. These are the OBRA guidelines that I'm not going to read, but I think it's important that whoever that is working with people on medication, actually, this is all the terrible things that can happen to a person that actually gets into this cycle of dementia with psychosis. Akathisia, this is basically a side effect of medication. The problem is that the person is agitated. You give them something that gets them to move like this, they're going to be more agitated, right? You see, agitation deals with problems, solving things, with loss, all these kind of things. And watch this. So when that government tells me that I have to be very careful in using antipsychotics in all people, I say, sure. But I have to remember also that this agitation can lead to a very undesirable result. What do we have here? This is just that you know that the same medicines that are used for schizophrenia, for bipolar disorder, can be used sometimes for dementia with agitation or something like that. But the doses are much. 0.5 milligrams in schizophrenia, actually people laugh about that. But it can be very, very effective in a person with a little bit of hallucinations when they have Alzheimer's. Here are different drugs that Dr. Igua put together as far as Risperdal has been used. Let me go back to Risperdal, because Risperdal is the one that has been, accused of causing excessive deaths by stroke and stuff like that in people with Alzheimer's disease. So we're tending to use Risperdal less and less, even when all the antipsychotics got the black box warning that they should be used with extreme care in elderly people with dementia. Olanzapine, possibly one of the most effective antipsychotics. Beware, olanzapine is very sedative. We give a little old lady 10 milligrams of Zyprexa, and what we're going to get is a fall and a broken bone. Quetiapine, this is Seroquel. Seroquel has been one of the most criticized type of antipsychotics, but it's still possibly the one that is used the most. Here is what I was talking about, the black box. In England, Dr. Iguana is in England, he knows a lot about England. So in England, they single out Risperdal and olanzapine for this particular risk. Here in the States, all the antipsychotics have the same warning. So is this important? Well, when you're dealing with good load people with Alzheimer's, and then you start getting calls from relatives saying, Doc, I don't want my mom to take that poison. You're in trouble, because you have to find another poison to replace the first one, because you feel that your patient needs that medication. You say, no, it's not a poison. Who says that? The government. Okay, the government is very powerful. I respect what the government says, I better do. These are alternative medicines. I think lithium is not very well in place to that. Lithium continues being the most effective anti-manic agent, and also has anti-suicidal properties. That has been proven statistically. But elderly people usually manage things like lithium very poorly. The others, well, you can give a try to many of them. This is a study with Depakote. I would try Depakote for one of those conditions, that is agitation, aggression. More benzodiazepines. Oh, give Granny a little bit of Valium. Okay. You know what? It works. It was hitting, etc. No, it's very calm. The problem is it works just for a few days, and later you have this thing. They get worse. These psychiatric effects for medic agents. Okay. Yeah, as a matter of fact, many of the medicines that we use to tranquilize people may cause more confusion, and that is to be avoided. This is just to wrap up. Disturbed behaviors are tools to diagnosis. Unless urgent, the complete assessment, not just the symptoms, determines the working diagnosis. Try to avoid medicines. Working diagnosis determines management. Consider side effects, especially these anticholinergic side effects. Treatment goals to enhance quality of life of patient and caregiver. That's. And with this, I stop. We have time for a question?
Yes, we have time for one or two questions.
We have time for one or two questions. Or observations, I think it is.
Okay, I think everybody's good.
Okay, and then we will conclude. This is my second talk. No more, eh? Don't be afraid. I'm not going to come back. I'm going to sit in the back.
Thank you very much.
Anyone has?
Thank you. Okay, I want everyone to stand up, stretch, because we got a 25-minute break. So we'll come back, 25 minutes. If we get straightened out sooner than that, then we'll start and then we'll let everybody know. And so we won't start without you. So We got snacks out there available, so go ahead and eat up because I know your blood sugar's pretty low. And I'll just boost it right back up. So thank you.